I think that's what maybe you could address if those aren't the silver bullets that are going to fix this system, because I agree with the chairwoman that and Mr. Shabbat that this is something that we keep band-aiding and band-aiding and band-aiding 6 months, 18 months. It's not long enough, and it's not going to work. And our doctors and physician healthcare system needs a fix. And we keep hearing that, well, we're at the next president. And I continue to say we can't afford to keep waiting for the next president to do something. If there's anything, this is going to be a tough debate and a lot of tough questions we have to ask ourselves. And it's going to hurt. And it's going to take all the stakeholders to talk about this. Some of the things I heard from a medical professional last week: 62% of all medical costs occur in the last 2 weeks of life. If that's true, I'd like to know that. And then that sparks a debate: is how, and nobody really wants to talk about this, but how we deal with end-of-life issues, and are we going to change things in that area? And that's going to take, I think, generations of this country and how we deal with that. We hear a lot about tort reform. I don't think you mentioned that in your statement. How much it is really about liability and tort reform? Is that one of the silver bullets that needs to be added in there? And then comparing apples to apples. I don't know if I have a question here, but if you could address any of these things that, who's giving what health care when I go in, a standard of care. And I don't know what I'm really asking, but we've got to start comparing apples to apples here. And I look at maybe it's a tier system. We've got to be able to talk out loud without getting your head chopped off or bringing these issues up. But, that one person's insurance policy or health care policy is the same as the next person's and a standard across the system. But maybe in those first ones about end-of-life issues, tort reform, maybe that helps.
A lot of good thoughts there, and I think you're kind of swirling around the area where all of us have been kind of grappling with on these issues, because if you really look at the current physician system, and as economists would say, you get what you pay for. So nobody should be surprised that we have this great volume and this intensity of services for physician payment, because when you really step back and look at it, it's a piecework system. It's a fee schedule. We pay on 7,000 different codes in this system. And what are all the economic incentives in a piecework system? It's to do more. And then you have this SGR cap on top of that, which basically penalizes all physicians equally. So if you're a physician that's practicing in an efficient way and someone else is practicing inefficient, you get hit just as hard as the guy that's inefficient. So it's really kind of unfair in that regard is how it looks forward. So a lot of the things that we're doing on our demonstrations and some of the programs we've already started to build in infrastructure start to get at that. One is dealing with this issue in terms of cost variation around the country. The folks up at Dartmouth, Elliot Fisher and Dr. Winberg have done some wonderful work about looking at great variation around the country, and a lot of it about end-of-life care. And we see sometimes 3- or 4-fold difference in terms of spending in different parts of the country, as you indicated, with no material difference in terms of the outcome of care. So one of the things we're really working with pretty collaboratively with the physician community is really to measure, because if you really don't measure, you can't really improve. And so we're looking at new measurement outcomes, new quality measures, efficiency measures, where we can start to measure this and where physicians can compare themselves one to another to see how they're performing, to see if we can get rid of some of this variation out there. So there's a lot of different swirling activities out there, but I think you're asking the right questions is how do we fundamentally begin to kind of look at where the gaps are in care, address those gaps and improve. And part of that, I think, fundamental foundation of what we're doing is in measurement in the future. To start paying for outcomes, not just pay for services.
That's all I had, Madam Chair. Thank you.
Thank you. Mr. Buchanan.
Thank you, Madam Chair. I want to compliment my colleague because from Indiana, I think he's got it right. This is a huge, serious problem. I'm in a district in the country, #1 as a member of Congress, with the most senior 65 and older, 176,000 according to groups. We got the baby boomers this year, first turning 62. Talked to doctors, head of our medical society, Dr. Mattel. Since 1991, they've looked at continued cuts, but yet 90 to 95, 85% of their practice are Medicare. Their expenses continue to go up in terms of taxes, insurance, and MedMel, and all these other things. And I know at the end of the year, a lot of them felt they were going to go out of business if they had that cut. So when we're talking about these additional cuts that we're talking about, and I think there was some thought early on with Medicare it'd be 20–30% of your practice, but in areas like Florida, in my area, I'm sure different parts of the country, it's evolved to 85–90% of the government. They're basically working for the government. So the bottom line, I just don't see, they can't attract a new doctor to our area. I think they've had one in a 300,000 population county, they were telling me, in one medical society. They can't attract new physicians to even come to the area because it doesn't make any sense. So I guess I want to get back to the whole point of, what are we going to do, or what's the answers as you see it to these cuts? And I think, as my colleague from Indiana says, it's tough to deal with this, but we really got to be truthful with the American people and put all these things on the table across the board, because, again, the first baby boomers turning 62 and you got 78 million to follow. We need to get real about that, and right now.
Those are very good points. And I think probably what you see in your district as much or more than anybody else, because of the numbers you laid out, is the fact that for the Medicare program to be successful, to really serve the seniors in this country, we need the active participation of physicians. It's interesting, there was a GAO report that came out last year that said basically 80% of all healthcare spending is driven by physicians, because they're the ones that order tests, they're the ones that admit patients, they're the ones that discharge. So we have to have active participation by physicians to be part of this program. And as you well indicated, depending on the physician specialty, their part of Medicare payer mix could be very low to very high, of almost 100% of their business. But the way that we guarantee active participation by physicians is to have predictability and stability in the payment system, and we have neither right now. So I can understand that uncertainty that your physicians are feeling and others are out there. And quite frankly, these are professionals that ought to be treated better by all of us as we go forward. And so what we can do with this program to try to manage that, to get better as we go forward, is going to be absolutely key. One of the things that we're really trying to deal with some of our other demonstrations here is really trying to look more thoughtfully in terms of the overall payment system in the Medicare program. Right now, when you look at Medicare Part B, it's pretty much siloed. It just, if physicians spend more to try to care for a patient more effectively, they see their payments cut as a result of the SGR because spending exceeds the target. But yet, because they might be managing someone with diabetes much more effectively, they might spend a little bit more to manage them more effectively, but they save that trip to the emergency department. They save that hospitalization. The overall system costs come down as a result of that. How do they be accounted for that? How do we reward them for that? And we're looking at new ways to do that. I think that's a good effort for the future and where we need to be going with this program. And I think we're getting some good support by the physician community to help us think those issues through.
I had one other quick question. I know we got to go vote, but one of my doctors called me, and I'm reaching out to the community, and said a lot of these young physicians are coming out with hundreds of thousands of dollars of debt out of medical school, and then they're trying to pick up a practice and additional debt to set up an office. And again, I just wanted to, he said, how in the world do you expect anybody to go into this profession with the realities they're dealing with? So it's kind of a follow-on question, but somewhat maybe just what you covered. But I think
that's a good point and a real concern as well, because what we really need right now in healthcare is more primary care physicians. And if they're looking at that kind of debt, they're probably going to choose specialties that are not primary care, and that is going to be a problem in terms of access in the future. So we've got to make sure our payment systems are fair, that they reward physicians across the board, and that we don't create incentives where people are abandoning primary care and moving into specialties, which I think could be one of the worst outcomes we could possibly see here.